Welcome to the Straight-Talk Physio Podcast with your hosts, Dr. Andrew Junak and Dr. Craig Giambattista. On today's episode, we're going to talk about the anatomy of the temporomandibular joint, or TMJ, how jaw pain is accurately diagnosed, exactly what our patients with jaw pain are experiencing on a daily basis, what a clinical assessment of jaw pain looks like, and effective jaw pain treatments that we use in the clinic every day with our patients that you most likely had no clue existed. So we'll kind of get this ball rolling by talking a little bit about what jaw pain is, or what is TMJ, and a little bit of the epidemiology, or how often or how frequently people actually experience this. So Craig, you want to get us rolling?
Yeah, absolutely. Definitely an exciting topic today. Something I think that might fly under the radar for a lot of people, because I think
Absolutely.
immediately when you think of jaw pain, you probably might go like, dentist might pop up into your mind first. So I think this should provide some valuable information to patients. So from a patient end, you might hear this as jaw pain. You might hear it as TMJ, which stands for temporomandibular joint. You might hear it as TMD. There's a couple interchangeable terms out there, but they typically all mean about the same thing. So when we talk about it here, it's basically just pain at the temporomandibular joint. So the joint itself is your mandible, jawbone here, in the mandibular fossa, which is kind of right by your ear here. So the TMJ is an interesting joint. You can actually kind of feel it work. So if you take your hands, put them by your ears, come forward a little bit, come down a little bit, open your mouth, close your mouth. You can almost feel some bumps kind of come out and move in between your fingers there. And that is essentially the temporomandibular joint. Something interesting about it is the mandible kind of makes a concave or a convex little curve there that goes into a concave mandibular fossa up here. In between there is a little fibrocartilage disc, not to be confused with the discs in our low back. Even though they have some similar sort of chemical makeup, they do have a, kind of a different responsibility. But as our jaw is opening and closing, that disc can kind of alleviate some pressure. It kind of moves around a little bit, and it does have some various other roles, and we'll kind of get back to that later. As far as when do we see this kind of stuff, again, the data at this point is kind of showing that it's affecting a lot of people. 50 to 75% of the population is going to suffer one symptom of TMD at some time in their life, and it tends to be most prevalent in females. We'll go into some of those symptoms below, but as you listen to this, you might realize, like, I might be one of these people. So Drew, any other things that you typically like to talk about when it comes to, joint specific stuff, more detailed anatomy, any epidemiology stuff?
Yeah, I think it's important to talk a little bit about the disc that you touched on, because that disc in and of itself, a lot of times when people think about the disc, they think that if you have an injury to a disc, and the reason I want to bring this up is because we are going to talk about a little bit further into this podcast about the disc and some of the things that can happen with it. So it is really important to point out that there are different parts to this disc. So there's an anterior part, which is the front, there's a middle part, and then there's a posterior part. So the front part and the back part both have a blood supply and have nerve innervation. So what that means is they're actually more likely to heal than the middle part. So if there was any sort of damage to the front of the disc or the back of the disc, you actually have a better opportunity of just regular healing. You're going to have more nutrition in that area. So there's a chance for, one, maybe your jaw pain to go away on its own, or two, with treatment, your jaw pain can fully resolve. So it is important that we mention that. And then the other piece to this, there's a lot of debate on what's actually causing the pain. Is the disc causing the pain? Is the joint itself or the receptors within the joint causing the pain? Or we have studied that we have some information or data that shows that there is an area attached to the back of the disc called the retrodiscal pad. This pad, or this area, is actually a bundle of nerve fibers, blood vessels, and fatty tissue. And there is some belief that when this area gets tensioned, pulled, or stressed, or compressed, that it could have some semblance of the pain generator with TMJ or jaw pain. So it's really interesting. We don't have tons and tons of research on this joint. I know dental professions have been trying to treat this for years. Our profession, also treats this. There's some chiropractors that treat this. So really interesting joint. There's a lot of gray area here, but that's also what makes this joint fun for me to treat. So with that being said, we'll kind of move on to the next section. And how does the joint work and why does it matter? So Craig, I know you made a little bit of an allusion to kind of demonstrating how patients can feel the joint work by putting, their fingers pretty close to their ear, right at the insertion of that jaw and opening and closing their mouth. So what is actually happening there with the jaw joint itself?
Right. So I think the jaw can be a little tough because if we're talking about our knee joint, for example, I can kind of look down. I can watch my knee joint move. It kind of acts like a hinge. So I think the jaw can be a little bit tough because we can feel it ourselves, but we can't see it ourselves. Like I can definitely see my shoulder move, I can see my fingers move, but I can't really visualize my own jaw without, let's say, a mirror or putting my hand there.
Yeah.
So just kind of going on with the complexity here. The jaw kind of works in a combination of like a roll and slide. So our bottom jaw here tends to do a lot of the moving because, as you can imagine, our face bones up here that it's attached to, they remain pretty stationary. So the way that I was taught, or the way that I will talk to patients or kind of educate them on that, is if I'm kind of using my hands here as a visual aid, it kind of rolls and then it slides as it opens, and then as you close, it kind of slides back and then it rolls back as you close your mouth. So as you can imagine, if one of that, like, kind of synchronous motion isn't working quite right, we might be able to see some stuff come up on the examination, or we can kind of get in there and, just like any other joint, kind of move it around with our hands. But in the very general sense, or what I typically like to tell patients, it's that combination of roll and slide when we're opening, and then that combination of slide back and roll back when we're closing. And it's not like a two-step process. It's not like, okay, let's roll. When we finish rolling, now we're going to slide. It's more of it kind of it moves in synchrony. You can kind of tend to bias like a little bit more rolling first and then sliding to open, and vice versa when you're closing.
Okay.
But it is kind of like a combination of movement. Is there anything that you have to add, or any other education piece you tend to work on with people? Because it is a little more, I guess, a different than most of our other moving joints.
Yeah. So I would say that the interesting thing about the jaw joint is the rolling and sliding is part of the regular mechanics of the joint. And we don't always base our treatment off of the mechanics of joints. So if we're looking at the shoulder, we're not worried about so much how something is rolling and sliding. We're kind of just treating the tissue problem. With the jaw, we actually are a little bit more worried about that, because we'll think about it like this. Let's say the right side of the jaw is not rolling or sliding. So it's not doing one of the movements at the same time the other side is. So the jaw might actually curve over to that side. And this is actually called a C curve. Um, and so we need to be able to recognize this, understand what's happening at the level of the joint in order to correct it. So this little physiology, or exactly how the joint itself moves, is really important in our ability to diagnose and then apply the correct treatment to solve the problem. So again, like other conditions where we're not always so worried about what's happening and how exactly the joint is moving, with this one, we are a little bit more concerned about it. And then a lot of times people will say, like, do I need an MRI for this joint or an X-ray? Most of the time, MRIs and X-rays are not very helpful, unless we're thinking that it's not a TMJ problem. We're thinking that it's, something a little bit more serious, or something other than that. Maybe you have a fracture, or maybe on the flip side, you have a nerve problem, like a trigeminal neuralgia, or some different things like that going on. So typically, MRI isn't very helpful. Is there anything you want to add to that, Craig?
I would just back up with the whole imaging thing. I know if a lot of our listeners to this podcast, you've heard us say that imaging is just a piece of the puzzle. And I think with this joint, just like all the other joints in the body, that holds, 100% true. So just because it is in a different spot, or it is a little, mechanically different than some of the other stuff we talked about, we're still pretty confident that, X-ray, MRI, CT can maybe help with some stuff with this specific joint, but again, isn't the, the be all end all. It doesn't paint the complete picture. So
Yeah.
yeah, I'm glad you brought it up. As far as, when we're talking about pain that's actually coming from the jaw or the TMJ, is there anything that you look for, or is there any special way you go about ruling stuff in or rolling stuff out, or what's kind of your way of just looking at this stuff?
So there's kind of a couple ways that I go about it. I would say most of the patients that I see, they've already been to a dentist for their jaw pain. Very rarely am I seeing someone who has not mentioned this to their dentist at all, or their endodontist, or somebody that deals with teeth. So a lot of times they've had the tooth ruled out. So they'll go through. I work with pretty closely with an endodontist and two other dentists. And what they described to me is they'll do some heat on each of the teeth. They'll do some cold on each of the teeth, and they'll poke and try to probe and recreate that same pain that you're experiencing in the jaw. If they cannot do that and they've stressed every single tooth on that side of the mouth or the jaw, then they're pretty sure that they've ruled out a tooth problem. Now, there's some other tests that they'll do as well. They'll do some imaging and different things like that to look at the roots of the teeth and make sure that structurally the tooth is in good health. But if all that stuff checks out, there's a very, very high likelihood that we're dealing with jaw pain. So many times after these dentists have ruled out tooth pain, they will either refer the patient to me, or someplace down the line I'll see that patient and I'll know there's a pretty good likelihood that there's a jaw pain problem. So then I'll go through my assessment, and some of the things that I'm doing to the jaw is, first, I'm asking a ton of questions, and we'll go over that in a little bit. But the things that tell me that we're dealing with a jaw problem is if I can stress the muscles of the jaw joint itself, so the TMJ, the muscles of the upper neck. And my goal with stressing all these different structures is to try and recreate or reproduce the pain that you're feeling. So if the pain is on the right side of the jaw and I'm doing some stuff and it's recreating pain on the left side, that's not what I'm looking for. I'm looking for that exact same pain that you're experiencing on the right side of your jaw. If I'm unable to find that pain, then the cause is likely something else. So in those cases, I'll refer out back to the dentist or the endodontist or whoever referred the patient to me. I have seen a couple cases of, and these are rare cases, of what's called trigeminal neuralgia, where the trigeminal nerve, or the nerve that powers the muscles of the jaw, it will get very, very inflamed. And nothing that I do can recreate the pain. So in that case, I'll actually send people directly to a neurologist. So Craig, do you see something similar like that with jaw pain, or how do you go about diagnosing, or making sure that someone actually has a jaw pain issue that you're working on?
The one thing that I would add, and you did touch on it, but I tend to have I'm very interested by like the upper part of the neck. And I
Mhm.
think when we're talking about jaw pain and even tooth pain in some, rare but not impossible conditions, there are some upper cervical spine joints, some cervical musculature that can refer pain to, whether it be the jaw, the face, or even some of your teeth.
Yep.
So I think just kind of using that as a screen first is it's one of those needle in the haystack things. But if someone's having a real tough time with this, or if this has been going on for a long time, I would be willing to bet that if you have chronic jaw pain, there's likely something going on with your upper neck. I can't say that's just my clinical bias, but I think doing a detailed, upper cervical and just general cervical screen is important with these specific cases.
Yeah, I would say if I've seen 100 jaw pain patients, I've seen many more than that. But if I have seen 100, I would say maybe one or two out of that 100 have an isolated jaw problem where I've screened the neck and there's nothing going on at the neck. But the other 99 to 98 of those patients do have some neck issues that need addressed. And if we don't address them, their jaw pain's not going to get better. So I'm almost always treating headaches, neck pain, and jaw pain all at the same time. So management of this, when we talk about timelines, is a little bit different than other common orthopedic injuries because there's so much more sensitivity within your nervous system. So when I go about like figuring out what's going on with a patient and their jaw pain, we use a classification system. Or my goal is to classify them and put them in a specific type of category. So some of these categories are: one, articular disorders; two, masticatory muscle disorders; and then three, arthrides. So articular disorders have a little bit more to do with a disc problem. The disc itself is more the cause of the pain. The masticatory muscle disorders it's not so much the disc, it's more the soft tissue or the muscular musculature around the jaw joint. So maybe the muscle in your temple is giving you trouble with closing your jaw, or the masseter itself is giving you trouble with opening and closing. And these muscles are just being overloaded, so we need to treat the muscles directly. Or arthritis, where it's more, think about the joint is the cause of the problem, and the joint itself is stiff, tight, and restricting some of the movement. So based on this classification, we then provide our treatment. Now, I would never say that say we're dealing with a muscle issue, I'm never just only treating the muscle. I'm still doing things to the joint. I'm still doing things, that I think are impacting the disc. I'm still doing things that, impact some of these other areas, but there might be a little bit more bias towards what I'm doing muscularly versus some of those other areas. So with that being said, Craig, when you're doing an assessment, okay, and you have a patient sitting in your office, what's some of the most important information that you're looking to get from them before you even put your hands on them? Because I would say history taking is super important in this population. So what do you typically ask your patients, and what do you typically find?
So I would agree. Again, history, super, super important here. And any patient listening out there, this might be some good stuff to think about if you are considering, seeking some medical advice for your jaw pain. So we're always going to do our medical history, our standard questions. When did this happen? Any idea how it happened? What medications are you taking? The standard stuff. We're always going to do that. But when we're talking jaw specific, there's a couple extra things that I like to look for. So from more of like a standard, medical questioning, like what kind of like functional habits do you have jaw wise? So do you chew a lot of gum? What's your diet look like? Do you eat a lot of soft food? Do you eat a lot of hard food? Are you someone that grinds your teeth when you sleep at night? Do you
Yeah.
wake up with a sore jaw? Do you have any numbness, tingling going on in the head, neck, or specifically the face? Are you someone that gets a lot of headaches? Did you get a lot of migraines? The joint in the jaw is something that is prone to a lot of popping, locking, and clicking. Does that sound like something that happens to you? And I think the one thing that tends to get forgotten in this population is the background stuff. I'm talking our stress, anxiety, depression, any history of that. Because as you know, if you tend to be a little bit more stressed than average, and we talk about this with a lot of our chronic pain and other joint problems, is it can absolutely have an effect on pain in the nervous system. And I think from just like a layman's term kind of thing, sometimes when people get stressed out, they clench their jaw.
Yep.
I've been in that situation before, and that's something absolutely worth talking about. And then from like just a medical, like a past surgical history kind of thing, is we always want to know dental work in this specific population is way more important than like your average stuff. So normally if you're coming with shoulder pain and you had a root canal, I'm a little less likely to talk about it. But in this case, that would be, super important. So any other things, Drew, that you think are, jaw specific or stuff that, you're always asking or, you don't want to miss?
Some weird findings that I've had with the jaw, and I will admit this is an area that when I first started treating this joint, before I like kind of went through residency and things like that, I didn't spend a lot of time on family history. I think that's often overlooked and it doesn't get asked enough, because what I found was I've had two patients in the last 2 years of treating this joint that came to me. I asked family history, and they had reported rheumatoid arthritis ran in their family. Now, they didn't have any symptoms in their hands. So typically, if you're familiar with rheumatoid arthritis, you'll find that the hands are mostly affected, and then sometimes the feet, but usually it's some of the outer joints. And if you Google pictures of it, you'll see, hands with different types of deformities and things like that. Rheumatoid arthritis is a rheumatic condition that creates pain in some of the smaller joints of your body. Well, guess what? The jaw joint is one of those small joints. So I've actually had two patients where they were not responding to the treatments that I was doing. They weren't getting worse, but they also weren't getting much better. They went and we had this discussion like, oh, this runs in your family. Have you ever been tested for it? They said no. I referred them to a rheumatologist, and they did undergo testing, and they actually were confirmed to have rheumatoid arthritis, were put on a special type of medication, and their pain was gone. So it is also important to note that with this joint, there are other systemic diseases that from your family history can impact your recovery. And your recovery may not be 100% mechanical in that case. So, from our perspective, we're looking at this mechanically, trying to diagnose and figure out what's going on. But it's not always a mechanical issue. It could be more of a systemic issue. So, family history is one of those things that I think I've found that, if I'm not focusing on that, or if I forget to ask that, it's something I'm always coming back to, because not everybody is aware of their family history, but the people that are, it makes it very quick to help us rule in or rule out rheumatoid arthritis as one confounding variable there.
Yeah, that's definitely an interesting one, and just another highlight of why it's so important to kind of stay vigilant and do a lot of question asking. So, as we always say for all of our patients out there, make sure whenever you see whatever, healthcare practitioner, they're asking you these questions, and they're trying to be thorough, because, a lot of that subjective stuff is super important.
Yeah,
So
absolutely.
I did mention the clicking and popping earlier, and I think that's a pretty common, and maybe one of those signs and symptoms that can maybe make one of our listeners or patients feel like, man, something bad is happening, because like this never clicked before, now it's clicking. Is that when you educate patients on that, can you tell us, why does it happen? Is it bad? Is it good? Like what's going on with the noisy joint? Because I think that's something people, always have questions about.
Yeah, so this is probably the hottest question in the jaw pain world, right? What's the click? What's the pop? Where's it come from? What's the deal with it? Um, it's really interesting because this joint is different from all the other joints. Uh, what we are suspecting is the click is actually the sound of the disc moving in and out of place. So not to talk about like alignment and things like that, not to harp on that sort of thing, because in the spine, when we look at the spine, we have lots of data that basically tells us that alignment in and of itself is not really an issue in the spine. When we pop a joint in the spine, we're not necessarily realigning it. Gas bubbles are being released. However, within the jaw, we do have some evidence and some video evidence that does tell us that a click or a popping sound may be heard when a disc moves out of place. Okay. But what's interesting is not everybody that has popping in their jaw actually has pain. So this goes back to what we talked about a little bit ago of we're not exactly sure what the true pain generator is of the joint. Is the disc the thing that causes the pain? Is it that retrodiscal pad or retrodiscal area that causes the pain? Is it the joint itself? We really don't know for sure. But what we do know is that our treatment tends to help. So there's different classifications of the popping sound that you can hear from in the research. So one of the classifications is they call it anterior disc displacement with reduction. So it's just super fancy words of saying when you open your mouth, you get a click when you open, and then when you close the mouth, you get a second click. So the first click is the disc maybe clicking out of place, and the second click is the disc maybe clicking back into place. Okay. This is typically seen to be a very low level problem, and usually these folks may or may not even be painful. Then you have anterior disc displacement without reduction. So disc clicks out, but there is no second click back in. Okay, and then the disc just kind of settles back in place where it's supposed to, in between the two joints. Then that one could cause problems later on. So that's one that, we kind of see, we hear, patients know it's happening. That's something that, we tend to look into, and then we may be treating. I have had instances where I'm treating a patient and the clicking or popping completely goes away. I've also had patients where they are now pain-free, but the clicking and popping is still there. So it's hard to say whether or not the clicking and popping is associated with a bad thing. I would say if you have clicking and popping and you have pain, then you need it looked at. If you just have a pain-free pop, it's kind of a toss-up. I can't say from a research perspective that you need to go see somebody or you don't need to go see somebody. But to err on the side of caution, it's always good to have it looked at, because mechanically the jaw may be deviating one way or moving a certain way that is not conducive to how your jaw should move. Could it lead to a problem later on down the road? Not 100% sure. And then the last type of issue that we may see is, say someone goes and has a procedure done on a tooth or a root canal. and their jaw is open for a very long period of time. What can happen is that disc can actually slide backwards. So instead of sliding forwards, it slides backwards, and then it gets stuck in between the joint, and you get what's called like an open lock. So your jaw is actually stuck partially open, and you can't fully close it. So this is a problem that it's pretty rare that this happens. Most of the time, people are referred to like a dental urgent care, and then they will try to help unlock the joint, or they'll give them something to relax the masseter muscle or the temporalis muscle to kind of calm things down, and then they'll start to wiggle the joint around and try and get it to loosen up. I've only seen one of these, so again, it doesn't happen that often. Craig, do you have any experience with like a open lock?
I personally never seen one. I think it just tends to be, like you said, a little bit more on the uncommon end.
Yeah.
But I have talked to patients that do experiencing the anterior displacement with and without reduction, those being a lot more common.
Yeah.
So I would definitely say that, at least from our, small study number of our personal experience, that
Yep.
it tends to be in line with what the research says when it, when it ends up being, pretty rare. Follow-up question though. So,
Yeah.
and I know we didn't really talk about this too much before we got started today, but so with the disc problem, like in the spine, a lot we talk about putting people into these like uh, treatment categories, like maybe they have this joint problem, maybe they have this muscle problem. So in the jaw, do you ever see any patients or have anyone that you would consider needs to be in maybe more of like a stability category? So not that joints become loose, or not that things are moving out of place, but are there ever points where you feel like that maybe more, we can call it neuromuscular control, we can call it whatever you want, but someone that you think needs a little bit more, let's call it muscle coordination or muscle stability? Does that occur in the joint like maybe it can in in a couple other joints, or can the jaw dislocate? Like our shoulder, that's something we've seen. You can go on YouTube right now and watch a shoulder dislocation and reduction on the sideline of a soccer field. There's probably a million of those videos, and I guess we would consider that maybe a shoulder that needs a little bit of, quote unquote stability, even though that's not my favorite term in the world. Is that something that might happen in the jaw?
Yeah, so there's different types of curves you can see. So you can see what's called a C curve. And again, this is more on looking at how the jaw is moving. If the jaw moves in more of a C curve, then you're looking at maybe more there's a tightness on one side, or there's a stiff joint, maybe a muscle that's limiting the motion. Maybe the disc is the problem. But if you're seeing something called an S curve, which when you see them, you'll know exactly what they look like. Uh, the jaw will move in more of an S shape. Then typically there's this odd push and pull that doesn't make sense for the jaw. And this could be a muscle incoordination problem. So we don't have a series of tests that we use to diagnose or put someone in like a classification category of an kind of a coordination problem, or the muscles aren't working together type of problem. But yeah, it absolutely happens. And I would say it's probably a common type of jaw pain that I see, where we're seeing this sort of S curve and the jaw is moving in a kind of a goofy pattern. It's sort of atypical, or maybe it's different every time they open the jaw. So we're doing a lot of retraining. But I would say with all of these different types of jaw pain, whether it's the joint, whether it's the muscle, whatever it is, we're still doing some of those exercises no matter what. So treatment usually isn't so, I guess, one-sided or biased towards one thing. There would be some bias towards, if there's a muscular problem, we're doing more muscular things, but we're not just saying, oh, it's a muscular problem, we're not touching the joint, we're not doing any exercise, we're just focusing on, massaging the muscle, dry needling the muscle, those sorts of things. So great question. And I would also say, kind of with the dislocations, they do happen. Uh, if you think about boxers, people who do UFC, they're taking really tough blows to the face, blows to the head. Usually there's trauma involved with the jaw dislocation. We don't typically see jaws that are just so hypermobile that they just completely pop in and out of place. A lot of times people think their jaw is dislocating when they hear clicking and popping.
Mm-hmm.
They feel like, whoa, like that's bad. I don't want this to keep happening. But usually that's the disc in and of itself. So that's an awesome question, Craig.
And I think that last bit there is so important for whoever's listening. A lot of times, because I mean, I've had friends that tell me this. They'll say, "Well, I'll open my jaw real wide, and all of a sudden I can't close it.
Hmm.
I have knocked my jaw, quote unquote, out of place."
Right.
When in reality, likely just a anterior displacement of the disc. That at that point doesn't want to reduce without some sort of maybe it needs external force from somebody kind of deal. So
Yep.
just a little kind of I think a useful just nugget of information there. So
So,
when you
well,
do see these patients, what are maybe some things that they're experiencing, or what are like some common TMJ complaints that you hear?
so they kind of have all kinds of different things going on. And I'm going to let you talk a little bit more about the neck and headache side of things. But from a strictly jaw standpoint, if someone comes in and they only have jaw pain, so again, this is maybe 1 or 2 out of 100 patients, they will have pain following the course of the jaw joint. So it might start located over by the ear and it might radiate down, kind of following the bottom of the jawline. They might experience pain that radiates into the ear on that same side. So they'll almost feel like they have some sort of an earache. And this could be due to the jaw. I've seen tinnitus or ringing in the ears that people can experience along with jaw pain. And then by treating the jaw, sometimes this is kind of goofy. It can alter or change their level of tinnitus. I had seen a patient who had tinnitus in their ear, or this ringing, and they came to me with no jaw pain, and I could change the level of ringing by treating their jaw. But uh, I don't recommend treating these patients because you don't know if you could potentially make the tinnitus worse or if you can make it better. Now, if that patient came to me and also had pain and they were suffering, then I would have gone ahead and continued treating. But you can get that ringing in the ear as well. You can get clicking, popping, or catching or locking in that jaw joint, along with opening or closing. You can have pain with eating chewy foods, so gummy bears, steak, bubble gum, pretty much anything that causes your jaw to work excessively while you're eating. So usually I'll tell people, if you really like steak and you have jaw pain, like, this is your excuse to get the fillet. Like, get something that's way more chewy, or way I guess less tough to chew. So that's your excuse to spend a little bit more money and get a higher quality steak. So, and then also they'll have pain with talking sometimes, depending on how bad the jaw pain is. And then also pain with sleeping is a pretty big one. And we'll talk about that more with education. But if there's anything you want to add to that, Craig, I think it'd be great, especially since you definitely treat neck pain and tightness and some of the headaches along with this. What do you see there? Like, where do these headaches radiate? Where do you feel the neck pain is? Is it on the same side? Is it on the opposite side? Where do you go with this?
So a lot of times I'll see upper neck pain, at least when it comes to the jaw pain world. And I think I'll preface with saying this: like, depending on how well versed you are in anatomy, anyone can make a case that everything is connected. We hear that saying a lot. I like that saying and I dislike that saying, because I think if you dig hard enough, you can absolutely say that, there is the TMJ joint from a muscular stand or fascial, there is a connection to the upper cervical spine, and can we prove that what mechanically is happening there is having a direct effect on the jaw? Maybe yes, maybe no. I don't think there's anything overly definitive. And that's even just back up and say, are mechanics even that important? So that's not a debate we're going to have today. But what I can tell you is that from a treatment standpoint, there is some research out there, and they're not huge studies, but I think they're absolutely worth talking about, that patients with jaw pain will experience relief with some soft tissue work to the suboccipital muscles, where they're a small group of muscles that kind of help attach the bottom of the head to your upper cervical spine. Or people will get upper cervical manipulation, it can help with jaw pain. Or people will essentially have work on a group of muscles called the deep neck flexors, and it can help with jaw pain, and vice versa. So I do think we don't, we're big fans of not saying, correlation and causation are two different things, but there's good enough research out there to say that addressing the upper cervical spine can absolutely have a positive impact on jaw pain. So I think that we can draw that connection, that the two structures are so closely related that they need to be at least looked at independent and together when we're talking about, with jaw pain, headache, that kind of stuff.
Yeah, I can't tell you how many patients I see who have said, "Oh, I went to a provider and they manipulated my jaw, like they popped their jaw and they did, some different techniques there, but didn't address the neck, and they didn't get the result they were looking for." So I think it's really important to look around to some of those other joints, especially the neck. With this one, I'll even look at like posture, shoulder blades, and some of those muscles as well. I'll go even down a little bit further than the neck, just to make sure I'm not missing anything or there's nothing else that I'm seeing, because it definitely doesn't hurt. And sometimes those little things might just be enough to keep the condition rolling a little bit further than it's supposed to.
Yep. So when we're talking about, one thing we always like to hit on this podcast is, education and timetables for stuff. Because I think in our profession, the medical profession in general, we tend to slack a little bit on how long does it take stuff to get better. So in the jaw pain world, what are you telling your patients, Drew?
Yeah, I think that's a good point. The medical profession, they tend to like to be super conservative, I like to say, and they don't like to give estimates. But I'm not. I've seen enough of these cases to where I'm pretty comfortable giving estimates for certain types of jaw pain. So let's say a patient comes in and they're the 1 or 2 out of 100 that just have jaw pain. They get 0 headaches. They have no neck pain or discomfort. Their neck checks out. Everything looks great. They just have some jaw clicking, popping, and a little bit of pain. I'd say the recovery is super quick. Like, I've had very, very good success with those patients because it's an isolated problem. It's like somebody coming in and saying, "Oh, I just have knee pain." Versus the person who comes in and says, "Well, my back hurts, my right hip hurts, my right knee hurts, and then once in a while I get some pain radiating into my calf." It's 2 completely different patients. Their nervous system is in 2 completely different places, and so we have a lot of different changes that we're trying to make. So if it's an isolated jaw pain problem, quick results, maybe 4 to 5 visits. Boom, done. Now, if the patient also is experiencing neck pain and headaches, then the recovery takes longer. Okay. How long? It's really hard to tell with this population because it depends on how sensitive the person is. It depends on if the person also struggles with other things like anxiety. If their job involves them sitting and talking on the phone, like if you have a sitting job and you're in a poor posture all day long, then we need to change lifestyle habits. So it really depends on how many different aspects of the patient's daily life we need to tweak and alter. Is the patient active versus is the patient, do they never exercise? Their favorite exercise is kind of watching Netflix. Well, that completely changes some of the different recovery methods that we need to use, because now we need to condition their body to hold a good posture, be stronger, and begin this new exercise routine while keeping their pain levels down a little bit lower. And then lastly, I also tend to educate patients on the length of time based on how long they've had symptoms. So if a patient comes to me and says, "Listen, I got jaw pain, headaches, and neck pain. It started 3 months ago." You know what? That's a really good timeline. I feel super comfortable saying, you know what, this is going to take somewhere between 4 and 8 visits for me to patch up. Okay. Now, conversely, say another patient comes in and says, "Listen, I've had jaw pain for 5 years. It all started after, X, Y, and Z incident. And it's just been so bad lately. When the weather changes, my headaches get worse. I can't sleep at night." Like, those are, again, they might have jaw pain, neck pain, and headaches, but they're 2 completely different patients. One had pain for multiple years. One had pain for 3 months. So it really depends on how the patient presents, how long they've had the condition, and then whether or not this is an isolated problem. So there's a lot of different things that factor into it. But usually when I see somebody in the clinic, I can tell them, "Hey, this is going to take 4 visits. This is going to take 8 visits." Or, "Hey, this might be beyond 8 visits. We might need to maintain this over a period of time. I may not be able to get you completely pain-free, but if I can see you maybe once a month for tune-ups, or I can get you, if you're willing to commit to doing these exercises when you do have a flare-up, we can manage this over time." So there's kind of a loaded question, but I definitely think it's important, and that's what patients want to hear. What do you go by, Craig?
I kind of fall in line with you there. I think that, and it's kind of like this catch-22 when I say, like, we like to talk about prognosis to patients, but then we come back and we say, like, "Well, we're really not sure," kind of deal. It's like, I understand that. I totally get it. But I think the important thing is like, there are some conditions where we can kind of expect maybe a shorter timetable, and there's some that we can expect a longer timetable. And when I say specific, sometimes to me that's as specific as I can get, because I don't have a crystal ball. But I think maybe I should have rephrased earlier. I think we do a bad job in the medical system. If something we know is going to take a long time to recover, we don't tell the patient that.
Yeah.
So I have that conversation a lot where I'll say, you know what, this is something where we might have to dig in, and this could be, months of recovery. That doesn't mean you have to see me for months, but that means you have to be active in your own, medical care for an extended period of time. And I think some
Exactly.
people tend to respond a little bit better to that, even though it's not a specific number, but it's better to know, like, hey, this might take a while, and that's okay. It happens all the time.
Yeah, setting expectations is the number one thing to success, because if you're not on the same page with your patient, then it's really tough to develop a relationship and trust. So, no, I think that's a great point, Craig. So, what do you do as far as treatment then? So, you take a look, you assess, you find out someone has jaw pain, you identify a cervical spine component. What are you doing with these folks?
Sure. And I'll let you get into a little bit more of some of the specifics, because I think you see this way more than I do. But we can treat it just like any other joint in the body. We can do our mobilizations and our manipulations. We can work on muscle strengthening to those specific muscles at the jaw and the muscles around it. We can, talk about some coordination or some of our, quote unquote stability exercises. We can work on neck stabilizer muscles. We can work on neck stabilizer muscle endurance, just like we would any joint. But I think with the important part of the jaw and TMG stuff specifically is talking about doing some education as far as resting jaw position. And I'll let you talk about that, because I'm sure you do way more of that than me, and like some good oral habits and some good sleeping positions, and working on maybe some underlying stress and anxiety stuff, and finishing up with a little posture education. And not to get on my soapbox here, but as far as posture is concerned, it's our body is meant to be in any possible posture imaginable. We have many millions of degrees of freedom, and we can use them. But I think the problem sometimes can arise is when we're maybe in not the best posture for a prolonged position, and then it leads to a problem. So I think that being in any posture is perfectly fine, but I think the duration might somewhat pose a challenge. So, educating on that sort of stuff. So I don't know if there's any specifics you want to get into, Drew, or any stuff that you tend to lean on a little bit more. I think that would, be helpful for our listeners.
Yeah, and a lot of my education, I actually have a free guide that I created. It's called the Do's and Don'ts of Jaw Pain, and it goes through a lot of the education that I actually do in the clinic. So if you're interested in that, you can go to the P3 website, Peak Physiotherapy and Performance. It's p3physio.com, and then you can click on jaw pain, and then you can see some of that stuff. It will ask you to sign up, but you'll get an email with a nice PDF document that goes through all of these different habits in extensive detail. And some things that you can do if you are experiencing jaw pain. But starting out with the resting position of the jaw, a lot of people don't realize where their tongue is when they're just sitting around doing nothing. So if you're just listening to this podcast, think right now, where's your tongue located? Your tongue should be located on the roof of your mouth. Okay. Not your whole tongue, but probably about the first 1/3 of your tongue should be touching the roof of your mouth. If it's sitting at the bottom of your jaw, it's actually placing excessive stress on some of the muscles of your jaw joint itself. So you want to think about that. If you're driving in your car, if you're super stressed, like, where's your tongue sitting? I know that's such a goofy thing to think about, but we got some pretty good research that supports that. The resting position of your jaw is actually with the tongue at the roof of your mouth. Okay. We talk about good oral habits. So again, not chewing on one side. So trying to chew like on both sides at the same time. Don't always shovel food to the right side of your mouth if you have right-sided jaw pain. Try not to keep your mouth open or in an open position for a prolonged period of time. Trying to sit with a better posture. Now, I know you mentioned that, the best posture is a changing one. And I totally agree with that. I think the other side of posture is, I typically don't talk a lot about posture with patients unless they're in pain. So I tend to find that posture in and of itself, as long as it's a changing posture, you're not going to develop pain. However, if you have pain and then you have poor posture on top of that, it's probably going to continue to give you pain. So poor posture in and of itself, will it cause pain? Maybe not. If you already have pain and you have poor posture, we may need to correct your posture for a short period of time and work on your posture to help desensitize you and keep you in a better position. As far as night splints, this is a super common thing that dentists recommend uh, and different professionals that deal with teeth. Uh, the research isn't great for them. Insurance typically doesn't cover them. Um, I think they may be a good place to start. Some people do get relief from them, but I'd say it's 50-50. There's half of the people will come into my office and they'll say, hey, I wear my night splint every night. It gave me a little bit of relief. And then the other 50% will say, I tried to wear the night splint. It takes up a lot of room in my mouth. It feels uncomfortable. The one thing that I'm typically concerned with about night splints is if it takes up a lot of room in your mouth, it takes you out of the resting position of the jaw. So if we know that that resting jaw position is what essentially helps keep some of the muscles at bay and not overworking, then why would we want to take you out of that position? So I really think it's highly dependent on the night splint. I don't usually recommend night splints unless I'm unable to help a patient get out of pain. That's when I'm kind of recommending them. So for me, they're more of a last resort, not a first option. That being said, if your dentist recommends one and you try using it and it works, great, keep using it. If it doesn't work, there's other options out there for you. I also educate on sleeping position. If you're a back sleeper versus a side sleeper versus a stomach sleeper. I think the hardest one for people with jaw pain is a stomach sleeper because their head's going to be turned to the side. So this is going to contribute to some of those neck issues that we were talking about. So a lot of times I'm either changing the way people sleep on their stomach to where they can sleep with their head in a more neutral position. So their head's not so turned to the side, or so we're changing some of the habits with sleeping on your stomach. If you're a back sleeper and you have sleep apnea, for example, we might be talking about putting you up on a wedge when you sleep, because for one, that's going to help with your sleep apnea. And then also it's going to keep your mouth closed throughout the course of the night. If you're a side sleeper, usually you're in a pretty good position. Sometimes if the jaw is super sensitive, you can't sleep on the side that you are experiencing jaw pain. So sleep position is another thing that we tackle. And then lastly, this isn't my area of expertise. I'm in no way, shape, or form a mental health provider or counselor, but one thing that we do know is that anxiety and stress can lead to clenching and bruxing of the jaw. So I am talking to my patients about meditating before bed. And this could be something as simple as using a free Calm app on your phone that you can just turn on some light meditation and fall asleep to it. Or during the day, if you're feeling high stress or high anxiety, just close your eyes and meditate for just 2 to 3 minutes. It doesn't have to be much. Nowadays with Apple Watches, my Apple Watch cues me like every hour, every 2 hours. I don't even know how frequently, but it will tell me to breathe. Okay. So these are just simple little tactics that can help reduce some of the stress to the jaw joint. So for me, I'm spending a ton of time on education, almost as much time on education as I am treating. And then I'm checking in on education in between visits. So I know I went probably a little bit over on that one, Craig, but is there anything you want to add to that or anything else you do like mechanically for hands-on treatment with these folks?
I would say, just kind of backing up to what we've been saying this whole podcast, is it is a joint. So we can get in there with our hands. We can mobilize the TMJ. Some people can even manipulate it. So don't be, patient-wise nervous or weirded out if your physical therapist is putting their fingers in your mouth. Definitely, a little strange the first time it happens, but a very valuable and valid technique. And I think for anyone out there that has tried this in the past, you might have, Googled some of these exercises and you might have seen the Rockabato 6x6 exercises. It's all good stuff. But I think circling back to what we tend to say a lot here is, as you can tell, there are many different ways to treat a joint. The jaw is no exception. What you need to find is someone that's very skilled at figuring out the best way to go about treating that specific joint. And I think that's where a physical therapist is kind of the perfect person for that job.
Yeah, and I think it's really tough to find a physical therapist who's, and I don't know why this is an issue, but so many physical therapists are afraid to put their hand in someone's mouth. I don't know what it is. Patients go to the dentist and they expect to have their like tools go in their mouth and hear grinding and like sanders go off in there. Like they expect that. But I guess like when you go to your physical therapist, you don't expect them to stick their thumb in your mouth, right? So
People always get nervous when we put gloves on. So
yeah, they're just like, what's going on here? What are you going to do? You know? And also I want to make a point about dry needling too. So I do some dry needling with the jaw. And I use very, very small needles. It typically is not painful. I have had some patients be a little anxious about it, so I don't use it with them. But if I can make like a little public service announcement here about dry needling and some of the jaw muscles, it actually doesn't hurt. Most people don't feel anything. And, I've had 13-year-olds come in with really bad jaw pain, and I've done some dry needling in their masseter muscle, so their temporalis, the lateral pterygoids, and they pretty much had no issues with it at all. So if you do have jaw pain and you hear we talked a little bit about dry needling today, it really isn't bad. It's very, very comfortable. The needles that we use are so tiny, you almost don't feel anything. So with that being said, Craig, I kind of want to wrap things up here. If you can give us some key points from this podcast or key takeaways that you think our listeners should get, what's your takeaways? Like, what do you got for us?
Yeah, I got 3 of them, 3 big ones for today.
Oh, okay.
So number one, just like a lot of other joint stuff, but maybe even more a little specific to the jaw, especially with our chronic stuff, doing activity modification things like checking out your resting jaw position, just kind of keeping an eye on your oral habits and your posture could be a nice fix to something that has been going on for a long time, just because, no one ever told you to think about it. So definitely be mindful of that. Number 2, the jaw, similar to any other joint in the body. I probably said that at least a dozen times this episode, but it's just something that is not commonly seen in the PT world. And some people don't even know you can see a physical therapist for this kind of stuff. So just know, like any other joint in the body, mechanical treatment to it can absolutely help it. And number 3, there are definitely more options out there outside of the night guard. Kind of just going back to what we said before. Normally when jaw pain, we think dentist, and then one of the first lines of defense there is the night guard. Can it help? Absolutely. And if it does, continue to use it. But if it doesn't, just know that you have other options out there.
Awesome, Craig. You killed the key points.
Yeah.
I think that's exactly what I would say too. You killed it, Craig. I really do think that most people don't understand that we treat this, and hopefully this podcast, gives some of you people who do have jaw pain or some of the jaw pain sufferers out there some hope that more can be done for you, because a lot of times these people suffer for a very long time with this debilitating disorder. So if you guys do have any questions or want to reach out to us, feel free to contact us at the Straight-Talk Physio Podcast at gmail.com. For people who are local to me, feel free to reach out to me at andrew.junak at p3physio.com as well. So thank you so much for tuning into the Straight-Talk Physio Podcast. If you like what you're hearing, it would mean the world to us if you subscribe to this podcast and the Peak Physiotherapy and Performance YouTube channel. For more information about us, please check us out on Facebook at Peak Physiotherapy and Performance and on Instagram at P3 Physiotherapy. For more information about Dr. Craig, you can follow him at Dr. Craig G_PT on Twitter and Instagram. If you have any topic suggestions, comments, or questions, then feel free to email us at the Straight-Talk Physio Podcast at gmail.com. Thanks again for watching, and we hope you have an awesome day.